was a year that we had more significant funds going into outreach. It's not that more kids have lost eligibility. It's not that we have fewer in need. We have 10,000 fewer kids in My Child Today than just a few years ago. And we think it's principally because of the issue of outreach and making it easy for people to get into the program. And so I will tell you this is very important. 16% of the currently uninsured are currently eligible for Medicaid under the rules today. 16% of those who are uninsured. So we don't have to wait for 2014 to start getting people enrolled and covered. We can do it anytime, but we have to focus on outreach. And I just think it's really important to understand. This tells you a little bit more about how people get distributed after reform, and the fact that many people who are uninsured today will be eligible for subsidies, will end up in the individual market. And I think, again, very important to understand, there is another myth out there that many of the uninsured are well off and they just choose not to get coverage. In fact, most of the uninsured are the working poor, and they don't have coverage because they can't afford it. And so that's, I think, again, something very important to understand. This gives you just a sense of the income group, the income distribution. For those who are between 134 and 400% of poverty, based on income, they would be eligible for a subsidy at the federal level. Now, most of them won't get that subsidy because if they already get health coverage through their employer, they become not eligible for the subsidy. So they're mostly, it will be those who are in the individual market who are at that income level who will take advantage of that subsidy. And this just gives you, again, a sense of what I told you earlier, how big we think the exchange could be. We think it could be at least as large as 1.1 million people. Those are the folks who are either individually covered today or who will be required to make that individual mandate, plus some of those who are in the small, who work for small businesses and don't have health coverage today. Now, we don't have perfect, pure numbers on that because some of those who work in small businesses where their business doesn't provide insurance have purchased health coverage themselves. So we didn't want to double count those people. So I think it's actually likely to be more than 1 million. It'll be less than 2 million, somewhere in that range. It'll be big. And so the exchanges will be very fundamental in the future to how people get their health care in Michigan compared to how they get it today. And this just gives you the sense, because it's the small businesses that become eligible for the insurance exchange, for that shop exchange. And this just gives you a sense of the percentage of the businesses in the state and the employees they represent. It's really quite a large number of individuals in our state who work for small businesses who could also in the future get their coverage through the shop exchange. And last but not least, right now there is a provision in the law that for very small businesses, under 25, there is a tax credit available to help them offset the cost of private health insurance. And if they're under 10, they get the maximum, 10 or under, they get the maximum amount of that credit. If they're up to 25, they get partial credit. They have to have an average wage of $25,000 or less. And that's, again, it's a lot of businesses, up to 144,000 businesses in Michigan, representing more than 700,000 people in our state are less than, or 25 or less. So we don't have the average wage data, so I can't tell you how many will actually get the credit or be eligible for the credit. But that's a lot of people in our state, a lot of people employed in the small business sector. And of course, to the extent we have growth in employment in our state, it's in this small business sector. So the tax credit is something available right now for businesses and something that many, many businesses in Michigan could take advantage of and could have available to them. There's our website. If you want more information, it's on there. And I encourage you to take a look at the other reports on the cost of health care and the survey that we've done. We will also be doing another survey this year to understand how people experience health care. And our first survey certainly did conclude with the fact that coverage is not enough, that people that many people feel they don't have access to providers of care even though they have coverage. And that's something we're going to explore a little more deeply in our next survey this year. So I would encourage you to go on the website and take a look at the survey as well as the other data. And I'm going to stop there and open it up for questions. Gilda. Oh, the two of you. That's
I'm
great.
sorry.
We probably have the same questions.
Well,
Okay.
you know, there is a movement afoot in the Senate to allow our states to opt out of certain
Provisions.
parts of provisions of this. Can you comment on that?
Yes, you know, what the legislation provides is a backup. I think that would be most unfortunate, because it's not that those things won't happen. The things that are state requirements that are in our summary of state, those are requirements. And so if we as a state decide, for example, we didn't want to implement the temporary high-risk pool, it's not that there won't be a high-risk pool in Michigan. It's that that is a case where it will be implemented by HHS, and they will most likely contract with a nonprofit to do it in our state. Same thing with the exchanges. If the state decides not to set up an exchange, federal government will set it up for us. So I think it would be giving away our future and our decision-making about how to deliver services in our state. It would be most unfortunate for that to pass. Was that your question too?
Sort of a flip side of it is how, like, it seems like there are a lot of responsibilities that are delegated to the states.
Yes.
And if we choose to implement these options ourselves, then we're incurring a cost in terms of staff and administrative costs to set these things up. And also in that 133% of Medicaid, it seems like, how are we going to pay? We're already having trouble coming up with a match for the existing population. So is there any additional funding for
Yes. Yes. So first of all, in terms of the administrative costs for all of the state requirements, there are administrative funds that were appropriated, not just authorized, to actually implement all of those provisions. Now, whether it's enough, you know, we know how much it is, 100 and some odd million for the temporary high-risk pool. Whether it's enough for everything, you know, that's probably debatable, but there is money there for the implementation. The states, it's not an unfunded mandate in that sense. In terms of the Medicaid match requirement, and Kaiser did a nice job on this as well. For the first several years, federal government pays 100% of the cost of the expansion. And then, as I said, by 2020, it goes down to 90%. So it's a better match rate for that newly expanded population than it is for the existing population. But yes, there is, by 2020, some state match that's required. And yes, we're having trouble right now. Certainly we hope by 2020 our economy is going to be better in our state, but you know, who knows. But the value, and a number of organizations, the Urban Institute and others, have done a tremendous job on talking about the value. You're getting $9 for every one the state spends. Now to cover you know, so many people, 286,000 new people, with full federal funding for 3 years and then tailing off to, you know, $9 out of 10 is an incredible value. And so yes, there are some cost increases to the state. I think Kaiser did some projecting on what those cost increases would be in Michigan. We can share those data with you as well. Eric?
Or Marianne,
Yeah.
this is really critical because it's a misconception. The Senate Fiscal Agency put out a report,
Yeah, some time ago.
and they analyzed that impact, and they concluded that offsetting those increases after 2016 would be a significant reduction in the community mental health programs and the population in those, and that in fact that would run at about $150 million a year of reductions, even in the 2014, 15, 16 when there's 100% match, and that by 2020, even with the state starting to pay 10% phasing in, the savings in the community mental health and a few other provisions would likely fully offset any increase the state paid.
Yes, and I think the other point, and that's, thank you for bringing that up, because the other point is there are also people who are covered by Medicaid today who will become eligible for private health insurance in the future. And so the Senate Fiscal Agency also made some assumptions. In the early years, it clearly saves the money, saves the state money. So when there is 100% federal, it saves the state money. The Senate Fiscal Agency was clear on that. In the later years, you know, again, we have to look at the assumptions of how people move and where they go. But if nothing else, it's a tremendous value for the state. Yeah.
What is the status of the
Class Act in the bill. So for those of you who don't know, there is Section 8 of the bill is what's called the Class Act. which I forget what it stands, Patrice, you'll remember what it stands for, community